Hello and welcome to this episode of Therapist Talk. Joining me today is special guest therapist Jodie. Welcome Jodie, how are you?
Assalamu alaikum, I'm well, thank you. How are you?
I'm well, I'm good as well, thank you very much. Really excited that you're joining us for today's episode because I would really love to hear about you and your work. So a real good starting point, I suppose, is would you like to introduce yourself? Who are you?
So, assalamu alaikum, my name is Jodie and I am a CBT, which is cognitive behaviour therapy therapist. And I'm in private practice as well as some third sector work with autistic adults. So I've got quite a variety of work which I enjoy.
Great. So yeah, I'm going to kind of deep dive into all of those and kind of find out more about you and your work. First thing that pops into my head straight away as you introduce yourself was that, very clearly a CBT therapist. And I'm sure that lots of people, lots of our viewers may have heard of CBT.
Yeah.
And of course, this isn't going to be a tutorial on what CBT therapy is, but how would you describe what CBT therapy is?
So CBT is a tricky one because if you Google it, there's lots of things going, you can do CBT in 2 hours and etc. etc. And they are usually CBT informed things. So they've got bits of CBT techniques and things in them, but they're not true CBT. CBT is a talking therapy, just like counselling, but it's looking specifically at your patterns of thought, your patterns of behaviour, and how that impacts on your emotions. So it can work on lots of different disorders like panic disorder, depression, social anxiety, but it can also work on just life problems that you might be struggling with, like stress. So it is an evidence-based therapy. There's lots of research and lots of trials that have been done to prove that it works. And yeah, it's a program of work rather than just using a technique here or there, which is tricky when it's not a protected title. So anyone can say they can do CBT, but the main thing is that people look at accredited CBT therapists because that's where you'll get a true form of CBT, if you like.
Yeah, but no, I think that's so important to kind of identify because, of course, as you said, anyone can kind of Google CBT therapy and it will kind of throw up a whole load of kind of techniques or tools, perhaps. But what I'm really hearing from you is that actually it's far more in-depth and far more broader than just a few techniques. It's a whole program, as you described it.
Yeah, absolutely.
Yeah. And then you mentioned that it can treat certain issues such as certain kind of phobias or like panic attacks, as you said. So do you want to say more then about the kind of issues and topics you work with and what clients bring to you?
It's quite varied. Now, I use 2 forms of CBT. So there's cognitive behaviour therapy as a kind of, it's almost like an umbrella term. There's lots of different types that you can do. I also use compassion focused therapy, which is linked to CBT, but in some ways quite different. So it can work on different things. So CBT is a kind of base therapy, if you like. Obviously, it's not basic, but as a base therapy, it can work with any depression or anxiety type disorders. It can also be used for more complex disorders, but that tends to be in multidisciplinary teams like psychosis and things like that. So I don't do that in private practice, but it can also, like I say, life problems like stress, bereavement, things like that. It can also be used for those sorts of things. The main thing is you do what we call a formulation. So you do an assessment and you understand why is the problem a problem now and why is it keeping going, why hasn't it gone away? And then you look at what skills or techniques do we need to do or what do we need to do exposure for. So things like phobias. Speaking of phobias, I've got a spider in my kitchen this morning. Hate spiders. So CBT for spider phobia would be I go and look at the spider and I get used to the fact it's there. And then I might get a little bit closer. So it's quite an active therapy as well as a challenging thoughts kind of therapy. So yeah, formulation, then you actually do the work. You hopefully, inshallah, see improvement. And then you look at how can we keep well from whatever the issue is that you've brought to therapy. With CFT, the compassion focused therapy, that's a bit more long term. So you can do it for much longer than CBT, and it can work on things like complex trauma. So if we've had difficult childhoods or difficult experiences growing up, it can work on a broad range of things like low self-esteem, self-criticism, things like that.
Yeah. So again, what I'm hearing is this kind of this combination of both the CBT and the CFT.
Yeah.
So the CBT feels like it's a bit more immediate. It's working on the specific issue that a client's bringing.
Yeah.
Whereas the CFT is working perhaps with their more deeper issues and traumas, as you said, like childhood issues or any deeper work.
Yeah.
And you can kind of work with both. They're very complementary, it sounds like.
Yes. Yeah, absolutely.
Yeah. And so going back then to specifically the CBT, you said because the CFT you said was longer term work, and you described the CBT as a program, is then I'm thinking about the viewers watching this who might be interested in going specifically for CBT therapy. What's the length of time you're working with clients then, and if it varies, what might be the different factors that might influence how long you might work with a client?
It can vary a lot. So the shortest I have ever done CBT is 6 sessions, and that was on a very simple phobia. You have a very straightforward program of work of exposure, getting used to the thing that you're phobic of, and then depending on factors like, is there any stresses going on? Is work okay? Is family okay? Essentially, if you're in an okay stage of life, and it's almost like this phobia is in a bubble and there's nothing else making it more complex, it can be very, very straightforward. In terms of how long it can be, so it can range from 6 sessions to 30 sessions. Bearing in mind, if you're having it once a week, that's kind of a year's worth of therapy. And that would be things for like OCD, because that's much more complex. There's a lot more things going on. Usually when people come to therapy for things like OCD, they've been suffering for a lot longer than some other things, because of things like shame, judgment, not understanding that it is a problem. So yeah, it varies significantly in terms of how long. It also varies in terms of frequency. So usually I start people on weekly sessions so we can get that formulation, that understanding down. And then depending on what the problem is, we might carry on weekly for things like OCD, or we might say, well, actually, we'll see each other once every 2 weeks or once a month, depending on what the issue is.
Yeah. Again, there's something about viewers watching this. For a lot of people watching the series, really, it's for them to really get an idea of kind of what different types of therapy are out there, different therapists, and then the different work that each of you do. I think it's really important, that idea, that because again, I think there's this real myth around CBT being a quick fix, like the idea of it being sticking plaster and it's 6 weeks and it's done. And actually you're saying, no, it depends on the actual issues that are being brought. And what I'm really hearing as well is, depending on whether it's kind of an issue that's kind of in isolation, in a bubble on its own, as you described it, or it's a bit more embedded in your life, such as OCD, then actually, because it's not in isolation, then it's part of your everyday. Of course, that's going to take longer to work with it, because it's not, it doesn't exist in a bubble on its own.
Yeah, the 6-week model is really interesting because, shockingly enough, there's no evidence base to say 6 weeks works for most disorders. The evidence base does not exist. The complication is that obviously in terms of services, they're trying to make it really affordable, and there's lots of other time constraints and pressures. So it's been boiled down to less sessions, and I think this is where CBT has a bit of a bad rep. And actually, CBT does not say it can fix everything in 6 sessions. It just does not exist out there in the literature. But a lot of the time, that's what CBT therapists in services are able to offer, because that's what the service says is on offer.
Right. That's, you know what, that's so interesting. So something about, so the model itself is not 6 weeks. No. The program, as you describe it, is longer, or however long it needs to be, but it's being kind of squeezed into 6 weeks purely through kind of structural service limitations, not because the CBT program itself is 6 weeks.
Yes, which is one of the main reasons I went into private practice, so I can do CBT as it's meant to be, because the constraints they stress therapists out, because you know that 6 weeks is not going to fix the issue that the clients come in with, and that's why we're in therapy, to help with whatever problem they're bringing.
Yeah, so I'm immediately kind of feeling kind of the pressure then on you as the therapist to say, right, I'm having to squeeze this far larger program, potentially up to 30 weeks, into a 6-week program, or space rather, and then the pressure on you then to, in a way, make out then that it's going to be effective in 6 weeks, when actually it needs longer time than that.
Yeah, it's almost like offering a fad diet and expecting it to be a lifestyle change, and we know that fad diets don't work, people yo-yo. So if you're wanting a lifestyle change, you need the time that's going to to change your lifestyle, not to change it for 6 weeks or so.
Yeah, it's not an instant fix.
It's not an instant fix.
And I suppose that's part of the bad rep, or the myth around CBT, which I think this idea that it is a quick fix, and actually you're saying no, it's not. It just happens to be squeezed into 6 weeks of sessions.
Yeah.
But the actual work and the program itself is not a 6-week program.
I mean, to put it into context, that formulation of understanding why a problem is a problem, where it's come about, I've taken 6 weeks just to understand that in depth. And that's without any active work that happens afterwards. Yeah. And the thing is, if you don't get the understanding right, your treatment is not going to be right. It's a bit like going to your GP and you've got, I don't know, an infection. If they give you the wrong medication, it's not going to do anything. They need to understand what it is and do a proper assessment so that the treatment is the proper thing.
Yeah. Yes, you need to have a really accurate idea of what the problem is in order to have find the most effective solution for it.
Exactly. Yeah.
Yeah. So just on that basis, I think, again, I find this really interesting. So this idea of actually you're squeezed, if you were to work in a service, to kind of, and the pressure on you then to kind of offer CBT in a constrained 6-week timeline. And you said, and that's why you chose to go into private practice. So do you want to share more and say more then about how you work in your private practice, and actually what that's then meant for you, I guess, then moving out of these kind of restricted 6 weeks and services and actually offering private practice? How's that been for you?
It's been an interesting journey. So I became a therapist in 2013, and I embraced Islam in 2014, which sounds like a big gap, but it was actually 2 weeks. So it was before New Year and after New Year. So for me, they are a very parallel process. And so I was learning about Islamic psychology as I was learning to be a therapist. And I really enjoyed being a therapist. But as I learned more, the more I realized the constraints that were on the evidence base that we were meant to be offering. So I started looking into private practice, became a private practitioner just before the pandemic hit. And alhamdulillah, it's been a really wonderful journey, because I've realized that actually my personality isn't a bad thing. I don't have to fit into a certain program and kind of be clinical. I can be a person, have a connection with people. But also I've got kind of 2 strands to my private practice. So I work primarily with Muslim women who are suffering with low self-esteem, self-criticism, things like that. And I also work with neurodiverse adults in charity and in private practice. So if they've had an autism diagnosis, or they've got a child with an autism diagnosis or ADHD, then we can work on processing that diagnosis, how it is to live in a neuro affirming way, so a way that is embracing of all different neurotypes. So yeah, it's been a really enjoyable process for me as a person, because I feel like I've developed, and that's, alhamdulillah, that's the beauty of therapy. I think you don't do it in isolation, you do it with another person, and I help each person I work with, but they help me too. And that's been a really lovely thing that I've been in for the past 10 years or so.
Wow. And I could really want to acknowledge that it's not even an idea, the reality, which is, as therapists, we are helping other people, but that process also helps us. It's a parallel process that's going on. And clearly, in what you've just shared with us, that you've clearly been on a journey yourself during the time that you've trained as a therapist, and then have continued working as a therapist in private practice.
Yeah, I mean, we're told that other beliefs are mirrors for us, and to me, it's very, very evident in therapy. You're working one-on-one with someone, you might be struggling with something, and then that client brings it up, and you're like, oh, this has been brought up for a reason. Let's talk about it. So it's it's something to embrace.
Definitely, yeah. I always say to my students, because I train therapists, and also to my supervisees as a supervisor, I always say we get the clients we need, not the clients we want. And the clients we need then are the ones that are that mirror to us.
Yeah, absolutely.
Yeah. I also want to pick up, Jodie, on a couple of things you just mentioned in terms of the type of clients and work that you do. So you said you work primarily with Muslim women, and you focus on issues around low self-esteem. So I'd love for you to kind of say a little bit more about that. I'm also just want to acknowledge as well, you mentioned also working with neurodivergence as well, neurodiversity. And again, that has been such a big topic on social media and in the news, and it's had so much more coverage over the last few years. And I think we're definitely seeing kind of this huge increase in people being diagnosed with different neurodivergent identities and diagnosis, and more people then coming into therapy because of it. So there are kind of 2 key types of clients that you're clearly working with. So I don't know which one you want to start with, but do you want to say kind of what your experiences of working with those client groups? How do you work with them? What do you tend to see coming into your kind of therapy room?
I would say with my Muslim women clients, because that's who I started my private practice with just over, was nearly 4 years ago. I was going to say just over 3, but it's nearly 4. So general things that come in: family conflict or complex family dynamics that they're trying to navigate, and that's quite tricky. Worries about getting married, worries about moving out, worries about how to manage a career and stay close to their faith. Things like, in work, have I got time to pray? How do I manage that? How do I manage that dynamic? Lots of low self-esteem and self-criticism, being really quite hard on themselves. And I suppose I see my role as someone to just say, you don't deserve that. I mean, life is hard enough as it is without having a bully that lives in your own head. So a lot of it is that kind of thing of helping people to realise actually they have worth, they have value, and they are worthy of taking my time up as a therapist. They are worthy of taking the time up of their friends and family because they are worthy as a human being. I would say that's the mainstay in terms of clients that come through that side of things. Things like anxiety, depression are often connected with low self-esteem, self-criticism, but usually the kind of root cause is the self-criticism rather than a clinical problem. It's almost like the roots of a plant. If you've got self-criticism and low self-esteem, the roots are going to present in different ways when they grow, like depression, anxiety, etc. But actually, until you get to the root of it, the weeds are going to keep growing. As any gardener will know, it's very frustrating. You pick them out, they grow up again. So that's that kind of side of things. In terms of the neurodivergent work, it tends to be generally that people have been diagnosed in their 30s, 40s, etc. Outside of school. They've had a difficult time at school, and then as they've got older, there are more things to juggle as an adult. If you have a job, if you have a car, if you have a house, if you have children, spouse, etc., it is just more to juggle. And I think for a lot of people, at some point the balance tips, and then they notice, actually, I'm struggling with these things. They've gone to a doctor, they've said, yes, we think you're autistic or ADHD, and then they come to therapy to go, so is my self-criticism because I'm lazy, or is it that's the way I've coped with having ADHD and not being able to focus? So a lot of the work is understanding what neurodiversity is and neurodivergence. Neurodiversity, the idea that anyone in the human spectrum is somewhere along a line, but neurodivergence is the idea that autism, ADHD, you can include things like dyslexia, dyscalculia, bipolar, and all those sorts of things as well, depending on who's talking about it, because it's not, again, not a protected term. So it depends on how people use it as a person, as an individual. So yeah, it is a variety of things. A lot of it, again, there's I think this is why I've been drawn to it, because a lot of it is self-criticism and self-doubt and questioning kind of your reality. Is this okay? Am I just making excuses for myself? So a lot of it is understanding what it is, and then understanding how to live in a way where you're going to actually make it accessible for yourself.
Yeah.
It's almost like if you think about people who use wheelchairs, if we have stairs everywhere, we don't go, well, there's something wrong with you. We say, well, there's too many stairs. It's the same with neurodivergence. We don't say there's something wrong with you. It means that actually you need some figurative ramps around the place, whether it's visual timetables, whether it's how to organize life, whether it's time management skills, whatever it might be, but creating those skills and techniques that they never had the opportunity to learn because it was missed in school. Yeah. So that in some way the two client groups are quite different, and in some way they overlap quite a lot.
That's the thing that I was about, I'm really, that's the thought going around in my head as you're describing it. Actually, there's such a big overlap here of actually, again, that root cause, like I said, the roots of this are around a sense of self, and that's about a level of self-esteem or self-worth or self-value. And ultimately, I suppose this question is, the question or statement might be, am I good enough? Or the statement being, I am not good enough. And that's kind of at the root of both of these client groups. Yeah. And of course, we're very intersectional in our identity. Being a Muslim woman does not make you mutually exclusive from being neurodivergent. You can, of course, be both. I am. I'm an ADHD. So for me, I can kind of really resonate with this idea of, as a Muslim woman, we're dealing with whatever comes up with that part of our identity, but it's not separate then from saying that but I'm also neurodivergent as well.
Yeah, absolutely. I think this is the thing, identity-wise, we're kind of put into boxes, and actually we don't need to exist in boxes. You might have your fingers in a few different boxes, and that's absolutely okay. If they help make sense of you for you and help you make sense of the world so that you can live in it without distress and suffering, why not?
Yeah, absolutely. Yeah. And a term that you mentioned earlier, which again, I think is really important, you talk about if somebody, if a client's coming to you because of neurodivergence, a diagnosis, or it might even be self-diagnosed, you know, again, we've got to get away from this idea that it has to be diagnosed from a medical professional. They might become because they're self-diagnosed or they're questioning about their neurodivergence. You mentioned then that the therapy you offer is neuro-affirmative or neuro-affirming. Do you want to just describe a little bit more? I'm aware of what that is, but I'm sure there are many viewers that don't actually know what that is. Because again, there's this myth that if I'm neurodivergent, therapy is almost like a conversion therapy. It's like trying to change me. It's trying to get, it's a diagnosis that I need to get rid of.
Yeah. This comes from, and people may have come across the term ableism, the idea that the so-called able are the normal, are the mainstay, the mainstream of the populace. Actually, we know that's not true. We're very varied as humans. Now, therapy, take that back to diagnosis. In terms of the DSM, which is how we diagnose, and this is where self-diagnosis has kind of come as a newer thing, all the diagnosis was based on white boys of a certain age, school age, who couldn't sit still in the classroom or were nonverbal. And that is what we deemed ADHD and autism. And anything outside of that, girls especially, can't have ADHD, it doesn't exist. Or there was a stage where we thought at 18, you just grew out of it, it just disappeared. Which, if your brain is different, it doesn't at 18 just become a new brain. Doesn't really make sense. So there's been this kind of emergence of self-diagnosis, self-identification. I know for me, I screen lots of people for ADHD and autism, and I score sky high for both. Have I got a diagnosis? No, I haven't. Do I need one? I don't know. I'm still on that journey to deciding, and that's okay. I think wherever people are in their journey is okay. Now, therapy, CBT, for example, was initially developed for adults, white adults in America who are middle class. So if you think about, say, a Asian girl at the age of 15 in the UK, it doesn't translate unless something is changed. There are therapies that are conversion therapies, like ABA, if people want to look that up. In America, it does look quite different to here, and that's for people to debate. And it is about behavioural change. I've yet to come across an autistic adult that has gone through ABA and not had harm done to them, sadly. So I'm on that kind of side of the argument, but I'm open to any other side of the arguments. I suppose the thing is, if you go for any therapist or counsellor who has not got an understanding of neurodiversity, you're not going to get neuro-affirming care because they're not going to know. Whereas if you've got someone, even if it's in kind of on the periphery of their awareness, at least they can then ask the question of what do you need, how do you need this to be? For me, neuro-affirming is almost like passionately accepting of this is the way you are and why would we change it? So if, for example, you come home from work and you're feeling a bit meltdowny, melty, overloaded, overstimulated, whatever it is, if you say to yourself, well, a neurotypical person would do X, Y, Z, well, you're not neurotypical, so why are you expecting that of yourself? If you need to sit and play a game for half an hour or play with, I'm looking at my wall here because I've got things pinned up, play with rubber bands or dice or pens or doodle, whatever it is to come back to a point where you can function again, you go for it. Standard CBT would not say to do that. It does not take into consideration about stimulation levels, about sensory input, about emotional dysregulation. It treats it as a disorder. It is a disordered, focused model. In terms of autism, ADHD, technically they are labelled as disorders. I personally don't consider them disorders, which is why DSM I take with a pinch of salt. They are brains. We all have different brains, and some brains have patterns with other brains. And that, to me, that is what neuro-affirming therapy is. It's accepting that we all have different brains, and therapy is about understanding you and your brain, not about Susan down the road or Bob up the street. It's irrelevant. It's what works for you and your brain.
Yeah. Thank you for sharing that, Jodie, because it's so important to kind of clear that up, that going for therapy, if you are neurodivergent, is not about then changing who you are. Neuro affirming therapy is about helping you cope with the world, helping you to feel supported in what you need in order just to be yourself in the world. So it's not changing who you are.
Absolutely.
And they are two completely different ways of approaching somebody who is neurodivergent and how we can support them as therapists. Yeah.
I think this is where identity is really tricky, because they're kind of putting you in a box of like, oh, you're a Muslim woman, you're an ADHD, and you're this, you're that. It's like, well, if the box is helpful, absolutely keep the box. But if it's not, and it's making you behave in a certain way that does not match you as you as your natural self, get away with the box. It doesn't help you. It has no function.
Yeah, absolutely. I can agree with you more. Absolutely. And just a real quick word then on specifically on diagnosis then, because again, I'm aware that in my own private practice, I'll get approached a lot being asked about, do you do ADHD or autism diagnosis? And I don't. So can you just give a quick word then on where you come in that journey for somebody in terms of them on their journey of discovery or diagnosis?
So usually the kind of, it's almost like 2 points of entry. I'm usually the person that goes, have we got some neurodivergence here? And then we investigate that, and then they go off for diagnosis. Or they've had a diagnosis and they come to me and go, I've been given this label and no aftercare is the standard thing. What is it? Am I mad? Am I crazy? Is it okay? And then it's about unpacking that diagnosis. The actual diagnostic process, if you're going for a clinical one, the NICE guidelines lay it out very, very clearly. Is a multidisciplinary assessment. It is not one person that assesses and go, yes, you're ADHD, yes, you're autistic. It needs to be more than one from a different field of study. So social work, nursing, occupational therapy, psychiatry, etc., etc. The idea is that it's not just one person seeing you on one day to go, oh yeah, they look a bit autistic. Oh yeah, they're bouncing around a bit today, ADHD, because it could be for lots of different reasons. So essentially the assessment process is ruling everything out to get to the point where you go, yes, it's probably neurodivergence of some description. So I don't diagnose because I am on my own in private practice, and anyone who does diagnose as an individual, take it with a pinch of salt, because it does not meet the NICE guidelines. I come in before and the after.
Great. Thank you for showing that, Jodie, because again, I can imagine there are lots of viewers going, oh, I'm on that journey, or I've been diagnosed, so whereabouts does therapy or counselling then can come in and help me? So that's really useful to know. So clearly then been in private practice for a number of years, and obviously been on your own journey through your own therapy as well. Is where you are now in your journey, based on your hindsight, I have a couple of questions. One is, based on your experience of training and now being in private practice and working with clients, what advice would you then give to somebody that's either just started their training or currently in training, or perhaps thinking about training as a therapist? What's the thing that you would have wanted a more experienced therapist to have told you when you started your training journey?
I think I went into therapy wanting to fix/help people. And I still remember my first lecture of my compassion focused training, and the person who runs it, Paul Gilbert, who is a psychologist who is in his mid-70s, he's been in psychology for a long, long time. And he asked, so who's here to train to help or fix people? And we all kind of and he went, you're all wrong. And we went, oh no, we're wrong. What does that mean? He said, if you're here to fix or help, you've got a savior complex, and that is not going to be helpful to your client. If you're here to be another human being in the room with a fellow human being, to be curious and see what's going to be helpful and not harmful, you're in the right place. And I think if I'd heard that in the beginning, one, it would have made me less critical as a therapist to myself, but it would also have eased the expectations I had in terms of, oh, well, we've done session 1, so this should be done. Session 2, this should be done. And I imagine as a very new young therapist, clients pick up on that, the idea that, oh, they've not done the homework, what do I do now? And that's not helpful. So I think the idea that you're there as a fellow human being, you're not an expert, you have your knowledge, they have their knowledge, you're coming together to share that wisdom to do something helpful, rather than you're coming as an expert to do therapy to people. I think that's the number one thing. I think the other thing is, depending on what type of therapy you want to go into, if it's CBT, go for an accredited course. If you don't go for an accredited course, yes, you can do CBT, but you will never be accredited, you'll never be registered. And that holds its own difficulties if you want to work anywhere other than private practice. So yeah, I think it depends on which modality you want to work in. But for CBT, it's the BA-BCP. BACP obviously is different, it's for counsellors, and CBT therapists can register with them, but for BACP, it does need to be an accredited course.
Yeah, and I'd actually want to kind of expand on that. Actually, for anybody thinking about training, make sure that training is eligible for you to become registered with a professional body, whether that's
Absolutely.
BACP or BABCP or many of the other professional bodies that exist as well.
Yeah.
So absolutely any training that you do, make sure it's eligible for you to become registered. Because as you said, you mentioned earlier on in our conversation about, you can jump online and do like a 2-hour course and get a supposed certificate, but it holds no weight in terms of actual legitimacy to go and get registered or get accredited. And actually, so those kind of courses are essentially a waste of your time and your money. Really do your homework. If you're going to do training, make sure you do your homework into getting onto an appropriate and right legitimate training course.
I think the other thing is, obviously we do go in to be curious, to be helpful as fellow human beings. If you're doing a course that is not accredited, not evidence-based, not above board, you could be doing harm in therapy, and that's the last thing that any aspiring therapist would want to do. So not only purse strings, etc., it's you don't want to do harm to someone else. You're going into this to be kind, to be helpful, so you owe it to yourself as well as the people that you're going to be working with.
There's something about, if we're going to shortcut ourselves in our training, all we're going to ultimately end up doing is shortcutting our clients, and that, as you said, that's harmful all round for ourselves and for our clients as well. Great. Thank you so much, Jodie, for joining me today, and thank you to all the viewers joining us. Such important points that you've made today, Jodie. I think kind of really busting those myths around CBT, but also in thinking about the type of work, and that specifically and especially in working and supporting Muslim women, but also neurodivergent clients. I think it's so important that people get the message out there to look then for neuro affirming or affirmative therapy and therapists.
So thank you so much for having me.
Oh, you're very welcome. Thank you, Jodie. And I look forward to all of you joining us for our future episodes of Therapist Talks. Bye for now.